Okay, well, good morning, everyone. It's my privilege this morning to introduce what is one of PCH's best kept secrets right now. Just out of curiosity, for all the residents here, not the craniofacial people, but for all the residents, how many of you knew that we have an oral surgeon on staff before you read the announcement about grant rounds? Okay, so I would say that's less than 20% of the residents that are here. I don't think it would be much higher amongst the attendings either, but this morning it's my privilege to introduce Dr. Jared Gilliland, who's an oral and maxillofacial surgeon at Phoenix Children's, and he's coming up on his 1-year anniversary here. And having been at Phoenix Children's for over 20 years, this is a huge asset that we haven't had most of the time, and we are still in the process of figuring out how to maximize the use of it. Anyway, Dr. Gilliland specializes in correcting congenital, developmental, and acquired surgical problems of the mouth, face, jaws, and TMJ joints, as well as facial trauma. Expertise includes the management of patients requiring orthognathic, which is corrective jaw surgery, TMJ surgery, and treatment of pathological conditions. The opportunity to care for children as part of Phoenix Children's cleft and craniofacial team was an opportunity that Dr. Gilliland could not pass up. He had the unique opportunity to travel to Belize on a medical mission to treat children with craniofacial deformities, and this sparked his interest in pursuing a career in healthcare. In terms of education, he completed his undergraduate studies at Baylor University in Waco and dental training at Baylor College of Dentistry. He then went on to complete a residency training in oral and maxillofacial surgery at University of Oklahoma Health Sciences Center in Oklahoma City. He's certified by the American Board of Oral and Maxillofacial Surgery and is a member of the American Cleft Palate Craniofacial Association and also the American Association of Oral and Maxillofacial Surgeons. Dr. Gilliland believes his work can have an immediate and long-lasting impact on his patients' lives. He cares for his patients and their families and works closely with them to address their needs and concerns. And outside of work, Dr. Gilliland enjoys spending time with his wife and 3 kids, playing golf, and being an active member of his church. And then the other thing I wanted to say before I introduce him, because he said this isn't yet part of his presentation, but apparently we are starting a pediatric dentistry residency here in just a few months. So for those of us hospitalists, this is going to make a huge game shift in how we handle all these kids that we get admitted for dental abscesses. And we're going to have resources on site that we haven't had in a long time. So without further comments, Dr. Gilliland, take it away.
Well, thank you for that introduction. I get the chance to talk today about something I'm passionate about and some of the primary surgical services I offer here at PCH, which is orthognathic surgery and treatment of temporomandibular joint disorders and associated pathology. A lot of you would better know it by the term corrective jaw surgery. Orthognathic surgery, just broken down, means straight jaws. And what orthognathic surgery is one or a combination of osteotomies in the face to change the relationship of the facial skeleton. In the maxilla, this most typically involves a Lefort 1 osteotomy. In the mandible, most typically a bilateral sagittal split osteotomy. And a typical adjunctive procedure that we may offer for cosmetic or functional purposes is a genioplasty or geniobustal advancement. So I'm going to use a couple patients throughout the presentation to kind of touch on some of the functional and cosmetic concerns that patients present with and what we can offer them with orthognathic surgery. So this is a 17-year-old female who has a history of right unilateral cleft lip and palate. She's undergone lip and palate repairs, alveolar bone graft, and pharyngeal flap to correct her facial deformities. Because of all this, she's developed significant midfacial hypoplasia and a large negative overjet. If you look at her dental photos, her upper teeth sit about 13 millimeters behind where they should, and it's presented a significant functional concern for the patient. She's not able to bite or incise foods like pizza or sandwiches. She has to chop things up and chew them only on her back teeth where her teeth occlude. Additionally, from a cosmetic standpoint, she's got a pretty significant midfacial hypoplasia. If you look at her lateral profile view, she's got a pretty stereotypical lower cleft lip deformity, midfacial hypoplasia, and a ptotic nasal tip. When she's smiling, she shows mostly her mandibular teeth, not much of her maxilla, and which makes the patient appear older. So we'll kind of touch on some of what we can offer this patient and the changes that we can make with corrective jaw surgery. So to make some of these procedures a little bit more clear, I'll touch on exactly what Lefort 1 osteotomy is. We make precise cuts through the zygomatic maxillary buttress along the anterior maxillary wall, through the lateral nasal walls, and then do a disjunction of the pterygoid plates to freely mobilize the top jaw to where it's only tethered to soft tissues. This allows us to move the top jaw in AP transverse vertical dimensions. And then once we have it in its final pre-planned position, it gets fixated into place with titanium plates and screws. The most typical osteotomy in the mandible is a bilateral sagittal split osteotomy, where we're making a horizontal cut on the medial aspect of the ramus above the entrance to the inferior alveolar nerve. And then that's carried down in the sagittal plane along the external oblique ridge, and then a vertical cut along the region of the first and second molars in the body of the mandible. And then we use a lot of instrumentation and osteotomes to carefully separate and split the mandible in a pre-planned fashion so that the osteotomy can slide on itself. We can move the mandible in AP and transverse dimensions. And additionally, I'll touch a little later on sleep apnea, but this can serve to open the oropharyngeal airway. And lastly, for cosmetic or functional benefits, we may offer the patient a genioplasty or genioglossal advancement. This involves an osteotomy below the exit point of the mental nerve, below the apices of the teeth, and then sliding that bony segment forward with the muscular attachments on the internal aspect, and then again, fixation with titanium plates and screws. So this is the patient from before. We offered her a Lefort 1 advancement and a small mandibular setback to help her not look too prognathic, as well as split the difference because she had so much scarring in her upper jaw. So from a functional standpoint, she's now able to bite, eat, and chew foods much easier with less jaw pain. And from a cosmetic standpoint, she's got much more fullness in her mid-face. Her lips now touch more appropriately. She's got more incisal show at rest, which gives her a much more youthful appearance. And she's got more support to her nose. She will undergo in the next few months a cleft rhinoplasty to finalize this surgical journey for her. But this patient presented initially and had complaints of low self-esteem, being bullied at school. And she, at her 3-month follow-up, was pretty happy, smiling, telling me a story of sitting with her family at a family reunion, talking to her uncle, who she's known for most of her life, and it took him 5 minutes to recognize who she was. So there's a lot of indications that would make a patient a good candidate for orthognathic surgery. One of the most common that we see is a skeletal malocclusion. And what that means is that the jaws are in a functionally unstable relationship where the teeth can't be corrected with braces alone. We can also do this for patients presenting with facial asymmetries, a lot of cleft and craniofacial conditions like cleft lip and palate, Pierre-Robin, Treacher-Collins. This may be indicated in patients with post-traumatic deformities. One of the most common facial fractures we see in the pediatric population is a symphysis and bilateral condylar head fractures, which, if they're inappropriately managed or not rehabilitated properly, can lead to gross restrictions in the mandible and malocclusions. This is a major benefit for patients of skeletal maturity that are suffering from obstructive sleep apnea, and this may be caused by or can help treat temporomandibular joint pathology. So some of the typical complaints, first and foremost, is often functional. These patients are having trouble biting, chewing foods. This can lead to pain as well in the muscles of mastication. A lot of times these patients are suffering from self-esteem and psychosocial issues from being bullied for their facial appearance. They often have cosmetic concerns that they didn't know could be fixed through a functional surgery like corrective jaw surgery. And again, I'll touch on sleep apnea in a bit and talk about what we can offer these patients. So this is a systematic review looking at quality of life outcomes in patients who have undergone jaw surgery. And what you can see here is self-reported significant increases in the patient's perception of their appearance, chewing function, speech, mental and physical health, self-confidence and social adjustments, their aesthetic perception of themselves. So when the patient's getting ready for surgery, about 6 weeks prior, we take an updated CT scan, intraoral scans, facial measurements, and upload it into a virtual surgical planning software where we move the jaws in this 3D software and fabricate our surgical splints and custom guides. And one of the reasons I like to include this slide and show it to patients as well is because two of the most common misperceptions we have with jaw surgery is one, that their facial is going to be fractured like in a car accident. And two is that we can fix their teeth, but this is not going to fix their cosmetic deformity, and they're going to have to go to a cosmetic surgeon to have that done. So this is the patient from above. He's a 19-year-old male with spinal muscular atrophy, wheelchair bound. And his biggest complaint is that he's got this anterior open bite, and he only includes on his back molars, which obviously poses a significant functional problem for the patient. That's the main thing he wanted fixed. When I saw him, I knew we could offer a little bit more. So in his surgical planning, we closed this open bite with a Lefort 1 osteotomy with clockwise rotation to increase his incisal show, and counterclockwise rotation in the mandible. This helps to open his oropharyngeal airway since he's lives a sedentary lifestyle in his wheelchair and is more prone to develop obstructive sleep apnea with age. And the advancement and clockwise rotation in the maxilla gives him more fullness in his midface and increased incisal show, which gives him a much more youthful appearance. So with this virtual surgical planning, we're able to add a significant level of precision into surgery. In the old days, they would take dental casts, dental models, a Facebook transfer, and do a model surgery to make the surgical splints and guides for surgery. And now we're able to plan surgery down to 1/10 of a millimeter to achieve exactly what we're looking for in the operating room. We're able to fabricate custom cutting guides, so the osteotomy goes exactly where it's planned. This is not a guesswork. This is not random fractures through the patient's jaw. And then custom plates to fixate that maxilla in the correct position. This also allows us to find perceived interferences where we may come into difficulties in the operating room and to anticipate those to make surgery faster and smoother for the patient. We can also map vital structures such as the inferior alveolar nerve to decrease morbidity in the operating room. So this is a 17-year-old male with a little bit of a cardiac history who presented with a significant negative overjet of about 15 millimeters. This patient was being bullied in school to the point that he couldn't ride the bus anymore. Mom was having to pick him up and take him to school. So he underwent a maxillary advancement of about 10 millimeters in a mandibular setback that gave him a class 1 occlusion. He's now able to function much better, and his confidence is through the roof. Now I'll touch on a little bit on obstructive sleep apnea and what we can offer. This is a great collaboration here at Phoenix Children's with the pulmonology and ENT department as well, especially since we like to delay orthognathic surgery until skeletal maturity. It's helpful to have sleep studies and also to have ENT perform drug-induced sleep endoscopies to further elucidate the level of obstruction when needed. And with orthognathic surgery, we can look at what we can offer in terms of opening up the airway. With the Lefort 1, we can advance the soft palate, open up the nasopharyngeal airway. We can increase the transverse dimension of the maxilla to open up the nasal passages and decrease upper airway resistance syndrome. With the sagittal split, we open up the posterior airway space at the retroglossal level. A genioglossal advancement can pull forward the genioglossus and geniohyoid to further open up that oropharyngeal airway. And some objective procedures that can be performed when the maxilla is down fractured is a partial turbinectomy and septoplasty to help with airflow through the nasal passages. So these are a few studies, including some systematic reviews that looked at the outcomes of maxillomandibular advancement in the treatment of obstructive sleep apnea and compare them to some of the multi-level surgical interventions that our ENT colleagues offer. And in this skeletal mature patient population, we saw surgical success and cure rates of 85% and 46%, which is defined as a decrease in greater than 50% of their AHI to less than 20 post-op, and surgical cure would be an AHI of less than 5. Typically, we're looking at bringing pagonion forward about 10 millimeters if possible. And like I said, this is ideally performed at skeletal maturity. Sometimes, if it's severe enough, we can talk about intervening slightly earlier. With our cone beam CT data, we're able to map out in 3 dimensions what that oropharyngeal airway looks like and find out exactly where the level of obstruction is to guide the planned movements for the maxillomandibular complex. And when I was talking earlier, genioplasty is pretty commonly known term, but genioglossal advancement may not be as commonly known. And all this, the differentiation includes is including the genial tubercle on the inside surface of the mandible, which is the attachment point for the genioglossus and geniohyoid, so that we're making sure that we open up that airway and pull forward the hyoid bone and that muscular attachment. So this is a 19-year-old patient who presented to my clinic. He's got a past medical history of autism, Ehlers-Danlos syndrome, developmental delay, and severe obstructive sleep apnea. His preoperative AHI was 94. He wasn't tolerating a CPAP. He was having trouble on BiPAP. And on the operating room table, as we're getting ready, he'd go about 45 seconds at a time with apneic episodes before he's able to take a breath. So his treatment included a Lefort 1 and bilateral saddle split and a genioglossal advancement to rotate his maxillomandibular complex and advance him about 14 millimeters anteriorly. And if we look at the axial slices of the CT scan before and after surgery, he gained about 5 millimeters in an AP direction in terms of that retroglossal airspace. But more significantly, since that airway is a three-dimensional cylindrical structure, he was able to gain over double the cross-sectional volume in his airway. He's about 2 weeks post-op now, and he's been off of CPAP since surgery. And the next thing I'd like to talk about is temporomandibular joint disorders and some of the associated pathology. To briefly touch on some of the anatomy here, try to make some of this more clear. This back here would be the external auditory canal. This is your glenoid fossa here with your superior joint space. Up above would be the cranial vault and the brain. This slope here is your articular eminence, which the condyle translates down as you open. This is the retrodiscal tissue, which attaches the disc posteriorly, the lateral pterygoid, which anchors it anteriorly. And this is your articular disc with thickened bands in the anterior and posterior, and the intermediate zone is most thin. And if you think about the intermediate zone should sit just anterior to that 12 o'clock pole on that condyle. And as you open and rotate this condyle down the articular eminence, those two should move as one. There's a bunch of disorders that can be included in temporomandibular joint pathology. This could just include a disc displacement. This could include arthritic or degenerative changes, neoplasm, congenital disorders where the patient has aplasia or hypoplasia of this joint space, and inflammatory or systemic disease. Some of the common symptoms we see with TMJ are pain with function, limitation in movement, and joint noises. These patients may also experience difficulty chewing, speaking, have headaches, and suffer from a malocclusion. And the differential can be quite extensive in terms of other findings that may cause this type of ear pain, limitation in function, and difficulty with jaw movements. So what causes an internal derangement? And it's a little bit poorly understood, but the best theory is there's some trauma in the joint space, whether it's macro or micro. Macro could be an intubation that was traumatic or prolonged time open on a bite block in a dental office. Micro can be parafunctional habits like bruxism causing compression of that joint space all night long. And the idea is that there's a oxygen tension in that joint space that causes free radicals to break down hyaluronic acid that makes that synovium much more thick and viscous, leading to adhesions in that joint space. There may be a role for joint laxity as well. While there may be an estrogen link, since we see such a high proportion of patients that are teenage girls just entering and exiting puberty that are presenting with TMJ, this hasn't been proven in the literature. Like I mentioned, parafunctional habits certainly play a role in this as well. And then once we have a clinical history of the patient in terms of what their limitations have been, how long this clicking and popping or limitation in movement has gone on, and associate with the findings that we get on CT and MRI, we grade them on this Wilks classification, which helps show us how severe the degeneration in that joint is and guides the surgical intervention that this patient receives. So the easiest interventions early on to look at this joint are the CT scan or Panorex in the office. This just shows bony structures. It helps us see what kind of arthritic changes we're seeing in the joint, if there's decreased joint space, bird beaking, or osteophytes. But most helpful in looking at the soft tissue in that joint is the MRI. And then we'll get into spect as we talk about condyle hyperplasia. So this is an MRI of a healthy joint. It's kind of flip-flop from the picture before, but you can see the posterior band up here at the 12 o'clock position, the intermediate zone at about 11, and the anterior band down here. And as the patient translates down that articular eminence, the condyle stays seated in that intermediate zone. When patients have clicking and popping in that joint space and accompanied pain, typically what you're seeing is an anterior disc displacement with reduction, which means that at the resting position, that joint is stuck forward with the posterior band anterior to the condylar head. And as the patient opens, they're able to recapture, but that popping here is the condyle going past this thick posterior band. The reason a lot of these patients have pain is this disc is an avascular structure, but the retrodiscal tissue that anchors it posteriorly is highly innervated. And as the patient repeatedly occludes on that tissue, it can cause pain. And you can see how close this joint is to external auditory canal, which is why so often they complain of ear pain and they often get sent to an ENT physician first. This would be an MRI showing that as well. Here, that disc is displaced forward, and as the patient translates, pops over that posterior band, that disc recaptures. Over time, this may progress to a disc displacement without reduction. The joint noises are no longer there, and this patient starts to have functional limitations in their jaw. For about the first 18 or 20 millimeters of movement, that condyle is simply just rotating in that glenoid fossa. And to get to your typical 40 millimeters of opening, that condyle has to translate down that articular eminence. If that disc is stuck anteriorly and is not recapturing, it acts as a mechanical obstruction. And one of the easiest ways to differentiate this from other causes of functional limitation is the patients typically have a pretty hard stop and you're not able to stretch them open past this point because of that mechanical obstruction. So this is one of my patients who had that. The disc is stuck forward here, and as you see, as they try to open, this doesn't recapture and that disc just balls up. First line intervention for a lot of these patients with these intra-articular disorders, as well as some of the confounding diagnoses on the differential, is going to be conservative therapy. This can be as simple as soft diet, moist heat, massages of those muscles, mastication, and physical therapy. And then when this fails, we move towards surgical interventions. The least invasive surgical intervention that I offer is arthrocentesis. The rationale behind this is to put two ports into that superior joint space. One's an inflow and one's an outflow, and use the hydraulic pressure of irrigation to help break up disc adhesions and open that joint space. And once we put about 150 or 300 cc's through that joint to wash out those inflammatory infiltrates, then we put something like a local anesthetic and a steroid to help with healing that joint, and then manipulate the jaw under anesthesia to try to get range of motion back. This is primarily indicated when a patient's got an acute closed lock that hasn't been present for a long time, or they've got pain that they can localize to a preauricular area, and we know that there's an internal derangement in that joint. Next, if the patient has a long-standing history of a disc displacement without reduction and functional limitations, and especially if it's been proven on MRI, then I'll talk about offering a arthroplasty with disc repositioning. What this involves is an incision along the tracheal cartilage in front of the ear to try to hide that incision, dissection down into the joint space, and then we manually break up those adhesions, cut out the hypoplastic retrodiscal tissue, pull that disc back over the condylar head in the correct position, and put a titanium anchor and ethibond sutures through that disc so that the disc and condyle function as a unit again. And then finally, just like in orthopedics, when all these less conservative interventions fail, or if the patient has severe degenerative joint disease or aplasia, hypoplasia of this complex, we talk about offering joint replacement. What this involves, as you can kind of see here with this red line, is removal of that diseased condylar process. We cut out the degenerated disc. This titanium base and ultra high molecular weight polyethylene serves as the new fossa component. And this titanium mandibular component with a cobalt chromium molybdenum head acts as a neocondyle. And as you can kind of see here from the stereolithic model, we often add this with Lafort's and genioplasties to correct the facial deformities that this degenerative process has caused. So this is a patient that presented. She was 16 years old. She had a significant facial clefting that led her with significant mandibular deviation to her right with an asymmetry. She's got maxillary hypoplasia, and she underwent a Lefort 1 advancement to correct some of this asymmetry, fix her midfacial fullness. You can see the total joint replacements posteriorly, and then an asymmetrical genioplasty to level out her inferior border. This is her profile view. On this portion here, you can see this massive bone in her temporal bone along her zygomatic arch that caused destruction and degeneration of her joint. So this patient has significant limitations in opening to about 14 millimeters that caused her to be able to only eat and chew very soft foods. So this procedure also offers to give her a functional joint with more normal range of motion. And on the left here, this is her before with really deep nasolabial folds, maxillary hypoplasia. She's got chin asymmetry with an obtuse cervical mental angle. And while this photo is taken about 3 weeks post-op, so she's still swollen, you can see that she's got a lot more mid-face fullness, significant chin projection, which gives her a more acute cervical mental angle, which is a lot more cosmetic. And then we're beginning to really rehabilitate her opening to get her to where she can bite and chew normal foods. The list of temporomandibular joint pathology is pretty extensive, so I'll try to focus on just what we see commonly in the pediatric population. First is condyle hyperplasia. Basically, what condyle hyperplasia is a non-neoplastic growth in that condylar head, which causes growth on a unilateral condyle that exceeds past the typical cessation of growth when patients reach skeletal maturity. There's two types. One's a horizontal growth vector and one's a vertical. The horizontal's much more common. And the two treatment modalities that can be offered is one, to surgically arrest the growth by shaving off the diseased portion of the condylar head through a typical incision like I talked about earlier with the arthroplasty, and then repositioning that disc. The other option is to allow this to burn out. The problem with that approach is that this may grow into the late 20s, early 30s. And at that point, we've caused a pretty significant facial asymmetry that's hard to correct. So type 1 hemimandibular elongation, what we typically see the patients complaining of is over time, they've noticed that their chin continues to shift laterally. And despite braces, they develop this unilateral crossbite. If you can see on the patient's right, her maxillary dentition fits on the inside of the mandibular dentition. And they often develop a class 3 underbite appearance. This creates a stress on the joint as well that can often cause internal derangements on the contralateral joint, necessitating both sides be opened up. And diagnosis of this is mainly clinical, but imaging does play a role. Specifically, a single photon emission CT scan and bone scintigraphy can show us if there's abnormal growth of the chondrocytes and osteoblasts in that condylar head. So this is a patient that has type 1 condylar hyperplasia. As you can see, her chin is shifting over to the right, and then intraorally, she develops this crossbite. Her midlines are off by about 5 millimeters, and this produces a malocclusion that can be painful in her joints, muscles of mastication, as well as make functional activities throughout the day difficult. The second type is hemimandibular hypertrophy, which is the vertical component. What we typically see here is the midlines stay on, but they develop a posterior open bite and they have significant bowing of the inferior border of the mandible. As you can see, this side's much further down than the other side. This particular patient is in Ivy loops because this non-neoplastic process caused such a dysmorphic condylar head that every time she'd open past a certain point, her jaw would dislocate. And she was taken to the operating room about 12 times to have her jaw put back in place before we were able to get her in the operating room. So this is a patient with that inferior bowing, and then as you see intraorally, she's got that large posterior open bite that can't be corrected with orthodontics alone. The patient that I mentioned above, this is her virtual surgical planning and what we offered her. This red portion is her proportional condylectomy to cut out that diseased portion of that condylar head. She got a Lefort 1 and sagittal split to fix the canting in her maxilla and mandible. And then we cut out the excess portion of the inferior border of the mandible to give her a more cosmetic appearance. Like I mentioned, that SPECT scan is really helpful. What we do is the patient's given Tech 99 through an IV, and this is taken up in areas of high osteoblastic activity, which is normal in the condyles, but If there's more than a 10% difference between the two condylar heads, then that lets us know that there's some pathologic process that's indicative of condylar hyperplasia going on. Another pathologic condition that can mimic this is an osteochondroma. It presents pretty similarly to type 2 condylar hyperplasia, but this is a benign hematomatous proliferation of chondrocytes and osteoblasts in that condylar head. And surgery involves surgical removal of the entire pathologic process. If there's enough remaining, then we can just do orthognathic surgery to put the jaws back in the correct place. But as this gets larger, typically it requires total joint reconstruction. The next thing that we see a lot in the pediatric population is idiopathic condylar resorption. And basically, it's just an idiopathic lysis and repair of the articular fibrocartilage that leads to loss of that condylar bone mass, decreased mandibular ramal height, steepening occlusal plane angle, and then an anterior open bite. It typically affects young adolescent females, which is why it's also referred to as cheerleader syndrome. It's about a 9-to-1 female-male relationship, and it usually develops during pubertal growth. It can happen idiopathically or after the start of braces. So this is a 17-year-old male who presented to our clinic with slowly worsening anterior open bite and recessed jaw that you can see is recessing into his throat. And this is a CT scan. You can see that he's lost his condylar height all the way down to his sigmoid notch, and that condyle is now translated anteriorly down his articular eminence, which limits his function, and he's stuck with that anterior open bite again, huge functional limitations and cosmetic burden on this patient. So what we'll offer him this summer is total joint reconstruction, a Lefort to advance and rotate his maxilla, and a genioglossal advancement to give him better chin projection, and once again, functional joints. Another process that can mimic this juvenile idiopathic arthritis. The difference here is that there's chronic inflammation in at least one joint. Commonly, the TMJ is involved, and it happens before the age of 16. It's helpful to get an MRI with contrast, which shows joint diffusion and inflammatory process, which is what's being pointed out in that picture. And it's really helpful to have rheumatology on board for these patients to try to stop the progression of this disease. Again, if it's controlled with disease-modifying anti-rheumatic drugs and NSAIDs, and we slow down the degenerative process in that condylar head, then the patient may be able to just have orthognathic surgery to fix the resultant skeletal malocclusion. And if it progresses like with idiopathic condylar resorption, then joint replacement may be the best option for that patient. And then finally, one of the most debilitating things that we see in the pediatric population is TMJ ankylosis. This can be due to trauma like condylar head fractures that we mentioned, or it can be due to middle ear infections. This patient on the far left here is a 5-year-old who developed significant ankylosing bone mass between his condyle and his cranial base. He was treated with gap arthroplasty, temporalis flaps, and distractors to hold that space open. In the middle here, we've got a patient that developed ankylosis bilaterally in her young adolescent years. She was treated outside with the gap arthroplasty, costochondral bone grafts to try to give her a functional joint, but sadly, those also subsequently ankylosed. So about 10 years, she had another gap arthroplasty with distractor placement to get rid of that ankylosing bone mass. But she developed a rotation of that mandible that left her with a large anterior open bite and pretty limited function in her mandible. And so what we offered her again was total joint reconstruction and a Lefort to balance out her facial profile and try to give her functional joints once again. And that concludes what I've got to talk about with TMJ and orthognathic surgery. I'd be happy to take any questions. Yeah.
Thanks, great talk. You mentioned that skeletal maturity is required for several surgeries. Is there any benefit to referring patients early if nothing else? Know that there's a path, and then kind of related question is there anything new in the realm of like augmented reality to like more define before and after? Like on that.
Sure. So to answer the first question, yeah, it's super helpful to see these patients early, especially to get them established with orthodontists that we know are comfortable treating surgical patients, and to let them know that we can offer something that corrects this, especially if their major complaint is a cosmetic, but it comes from the jawbones being in the incorrect position, to demystify and let them not think that they have to be vain and seek out a cosmetic surgeon for chin implants to fix what really needs to be a mandibular advancement. I think it's helpful that they get established early, and then we can kind of guide them to the right person. And then we demystify and help them cope earlier with what's going to be offered once they reach skeletal maturity. To answer the second part of your question, there are soft tissue overlays that show what the patient can look like before and after surgery. But we really only focus on the bony movements and what we're going to show and what we might expect to see cosmetically. From a medical legal standpoint, it's really been frowned upon and asked not to show the facial cosmetic changes because it's so patient specific and everybody's soft tissue moves a little bit differently. So we typically don't show before and after of what we might see cosmetically.
Or are they contraindicated to patient population for type of loss? Like, do they work together with that person, or is it?
Yeah, they can. So Dr. Scheffler offers a lot of patients that hypoglossal nerve stimulator here. And more so in terms of, we haven't done a lot of adjunctive, but usually it's the patients that to me aren't great jaw surgery candidates, may be great for hypoglossal nerve stimulator, or the patients that he thinks may not benefit enough from that or haven't benefited enough from that would be great jaw surgery candidates. It's really nice to have them on board because that can be put in, a 6-year-old with Down syndrome where I can't offer jaw surgery. But when all these multi-level surgical interventions don't produce the desired result, then it's great to have jaw surgery. Or some patients just have facial imbalance that's going to benefit cosmetically as well. And so it's kind of a killing two birds with one stone. Yeah.
And repeat the question for the Zoom audience.
So the impact that advancement can have on speech. In our cleft population, a lot of patients have speech disorders, but aside from our cleft population as well, when we make a lot of sibilant sounds and articulation, it's the tongue hitting the back of the maxillary dentition. And when that max is in the wrong position, it can cause a lot of articulation problems. So putting that top jaw in a more harmonious relationship with the mandible can allow the tongue to function more efficiently and make better sibilant speech sounds and let the patient sound more normal.
So when we see patients that are patient, for instance, with these sort of conditions, what is the best path to potentially get them to you? Because I see a lot of these patients that don't know that this is an option, and we don't all work at the same clinic, for instance, in terms of like our rotation clinic. So I'm just wondering if it's okay to put in an outpatient referral. And also, like, the best way to reach you, I always end up having to like go through plastics, and then eventually I get your name, and I'm always like, oh yeah, I remember that guy. He's part of our division. Yeah, and I always feel bad like texting plastics, and sometimes they're like, let me think, and then yeah, and then I'm always happy to reach out to you. You're so polite over there. Is that the best?
Yeah, definitely. I think, even like was mentioned before, if the patient's young and not quite ready, they get started in braces a year and a half. Sometimes, if they're doing 2 phases of braces, they start at 9 years old, and we can tell early if they're going to require corrective jaw surgery at some point. So establishing them early and letting me introduce myself and kind of taking some of the fear out of what can accompany corrective jaw surgery and show them some of our patients' post-op progress and walk them through what to typically expect is helpful. And then, yeah, if you've got consults for me, typically the easiest way is through our plastics department. And if you need, something specific, you can always reach out to me, email Vocera. I'm happy to answer that way.
And just a quick follow-up. Do you have like connections for like community orthodontists that you can connect patients to?
We do. Certainly if they're medically compromised, I like to use our orthodontists at the Cleft and Craniofacial Center because they're awesome. But there are several in the community that we work with, and I know insurance plays a role, which is one of the best things that I can offer these patients because a lot of providers in the community don't take insurance. So this costs $25,000 or $30,000 if you're out of pocket.
Got some good questions in the chat. The first one, I'll give you the easiest one first. What is your current wait time to see patients in clinic?
Short. I've only been here a year. I'll get them in fast.
Okay, second one, can you, and repeat this one, can you speak about the role of mouth guards, both over the counter or custom in TMJ disorders?
Sure. So the biggest role for mouth guards would be when patients have parafunctional habits like nighttime bruxism. The role of like something over the counter would just be to decrease the wear and tear on that joint, on those teeth. But also when we compress, there's compression in that joint space, which, like I said, causes that hypoxic reperfusion injury in the joint, but also just compression, degeneration of that articular disc or compression on that retrodiscal tissue. And so that just disarticulates the teeth a little bit to open up that joint space. There's other splints called anterior repositioning splints that can pull the jaw forward. Those need to be watched closely because they can develop malocclusions because of that. But there's a lot of stuff that some of our TMJ pain specialists in the community can also offer as we go through all these conservative therapies.
Okay, and then last question on the chat. How do you distinguish idiopathic condylar resorption from JIA-associated TMJ disease? And that's from the rheumatologist.
I rely on them. It's tough. Some of it's just based on clinical history and what we're seeing clinically, but a lot of times it's helpful to have an MRI with contrast to see if there's joint effusions, or having a full workup to see if there's other involved joints that might raise our suspicion for something more systemic than just idiopathic condylar resorption.
I'm going to start with my questions now. So first of all, can you talk a little bit about the management of dental abscesses, which we as a hospitalist, we see them all the time in the wards. Can you talk about what it used to be, what it is right now, and what it will be in a few months once that dental residency gets going?
Sure. So what it is right now is there's a collaboration between me and our ENT department. I reach out and let them know when I'm on call to help manage these. They've been huge and pivotal in helping decrease some of the burden on managing these patients with dental infections. When the abscess is small, especially so often in kids, we just get small vestibular space abscesses that may not necessarily need to be drained. They may respond to antibiotic intervention. And then as soon as they can, if we can get them into the pediatric dentist to take care of the causative problem, whether that tooth needs to be removed or have a root canal, that'd be ideal. And then slowly in the future, we'll have that pediatric dentistry residency program here. And those residents may be able to take a tooth out and drain in the ED, or they may join along to help out in the operating room. And we'll really rely on them for stuff that needs to be managed more surgically by myself or the ENT department to guide where that goes to for operative intervention.
Okay, thank you.
Yeah.
Can you speak to like what recovery from the surgery is like what is it kind of meaningful, some of the key kind of
Yeah. So first 24 hours afterwards, they're usually admitted for 1, maybe 2 days. We're just looking for pain control with oral medications and a good IV hydration. Typically, pain's not our biggest complaint after surgery. It's facial numbness from stretching on their facial nerves and just swelling, congested nasal cavity. But typically, pain's not our biggest problem. The first week is when they aren't my biggest fan, maybe don't love me so much. Once I get to the first week, it's really smooth sailing. Basically, our limitations are sinus precautions for 3 weeks since they've had an osteotomy through their maxillary sinus, and then soft no-chew diets, just so we're not putting any stress on that bony union. After that, we just start rehabilitating their opening. So 6 weeks of physical limitations, not lifting heavy things. They can go on walks, ride a bike carefully. They may be out of school for 7 to 14 days, but pretty quickly they can go back to sedentary lifestyle, going to school, sitting at a desk, that kind of stuff. Does that answer your question? Yeah. Okay.
I got one more. Can you talk about the 2 or 3 most common patients that you think are out there that are not getting referred to you just because people don't know?
Yeah.
That you would like the pediatricians and residents in the audience to know, be on the lookout for, oh, hey, that guy should go see Dr. Gilliland.
I think a lot of people are finding me for the TMJ issues. I think hopefully this presentation helps demystify jaw surgery a little bit, because I think there's a lot of patients out there with huge overbites, huge underbites that can't be fixed with braces, that don't know that this is an option, don't know the cosmetic benefits, or are afraid of financial implications when they're so often running into providers that don't take insurance and they don't have the funds to achieve what they're wanting to have done. That'd be probably the biggest thing.
It's been a while since we ended the grand rounds early, so I think it's we owe it to all the residents to get them back. But I wanted to make an announcement for next week. We have pediatric update at the Scottsdale Plaza, and we use the same Zoom account. So we won't have grand rounds next week, but for all the residents and any attendings who want to come, we will broadcast the breakfast workshop from there, which is 7:30 to 8:15 next Tuesday. So it won't be available on Zoom unless you register for the conference. But if you come here in person, Matt will have it up on the screen and you'll be able to hear. It's Dr. Michael Olson's giving the breakfast workshop on obesity, and he's going to cover the new anti-obesity medicines, indications for bariatric surgery, etc. So it'll be a very good talk. So just residents come here and you'll get the grand rounds experience, but it'll be part of pediatric update. So thank you all. Yes, and let's have Dr. Singh come up and make a quick announcement.
Good morning, everybody. Just quickly, I know it's been a little bit confusing for everybody. Okay.
Sorry.
Thank you for a great grand rounds presentation, Dr. Gilliland. It's been really confusing, I think, for the hospital and for everybody to understand that Dr. Gilliland is part of the plastic surgery division. So you should not feel badly about calling us. Our residents and our PAs provide coverage for Dr. Gilliland. And he is really based over at the Cleft and Craniofacial Center, but also operates here, sees inpatient consults, helps with coverage of facial trauma. He's been a huge asset for our patient population. Before Dr. Gilliland coming on, we did not offer patients TMJ joint replacement and this complex orthognathic surgery. So we are excited to have you. And I think as we build the residency program for pediatric dentistry, the services for oral health needs are going to become much more robust on the inpatient side.
Okay, we got one more important question.
Sure.
Okay. What aspects of workup help to convince insurance that these procedures are not cosmetic or purely elective?
Yeah, a lot of that is documentation in our notes, is what the insurance company is looking at, is functional limitations, and a lot of times just the photos, the intraoral photos show that the malocclusion is severe enough that these patients are suffering from these issues. We take a cone beam CT in the office that shows the skeletal relationship as well, and so the documentation is not typically the cosmetic changes that are going to happen, but that's an adjunctive benefit of a functional surgery to improve their health.
Okay. But if we're referring patients to you, in our notes, we can put in there that we're concerned about overbite, underbite, functional malocclusions. Okay.
Yeah,
great.
That's great.
Okay, thank you again.
Thank you. Thanks again for having me.